let's move on and let's talk about AR-targeted therapy for non-metastatic castration-resistant prostate cancer. Judd, you had talked about this large population of what we call M0 disease. So it's that CRPC patient that radiographically, when you study them, and traditionally it's been technetium bone scan or CT, that currently does not have metastatic disease. So Mike, I'm going to throw it to you first. So if you look at the AUA guidelines for M0 CRPC, that would be index patient 1 in the AUA guidelines, or if you go to NCCN M0, what are the current therapeutic options for M0 disease?
Sure. So we have limited therapeutic options. That's, I think, the amazing thing for us right now. Most of our drugs that we've just been talking about and we'll talk about are for patients who have metastatic castrate-resistant disease. So the M0 space is really completely wide open right now. So there are multiple clinical trials using some of the AR receptors inhibitors that we're looking at now. But really, hormonal therapy is the mainstay, androgen deprivation therapy. And that is even debatable as to when to begin it. Do you begin it when the PSA doubling time is less than 10 months? Do you do it when the absolute PSA is greater than 2? What is the factor? If you poll 100 urologists in the United States, you're going to get 99 different answers. And I think even medical oncologists defer to you guys to see. So we really have limited options in this space right now.
So basically it's observation or manipulation using existing anti-androgens, which of course do not have a documented survival benefit or a clinical trial. Now there have been a couple key trials that have been reported over the past year, and Chuck, can you go over with us a little, talk about a little bit about Imagine as well as Strive?
Sure. So Imagine, IMAAGEN, is a study of early abiraterone with low-dose prednisone in patients with non-metastatic CRPC. And the data, it was a non-randomized study, but the data basically demonstrate that virtually all patients will have some degree of PSA response. The 50% decline rate in PSA was extremely high in the 90% range. At this point in time, the study continues on, and the median time to radiographic progression has not yet been reached. The median time to PSA progression was in the 26-month range, so very, very long duration of time. So that's abiraterone, and I think notably it should be stated that this was abiraterone at 1,000 milligrams with 5 milligrams daily of prednisone, so not the 5 twice a day that we commonly think of in the metastatic setting. Strive is a study of enzalutamide comparing it to bicalutamide, and that was a study that was done in the that included a CRPC, non-metastatic CRPC component. Essentially, at the current rate of reporting, the median PFS and median PSA progression has not yet been reached compared to bicalutamide. However, when it comes to the hazard ratio of comparing bicalutamide to enzalutamide, the hazard ratio is around 0.2 in that range. So it's about an 80% improvement, it looks like, over bicalutamide in this setting in terms of delays in progression. So that study's still developing.
So Judd, how do you think that plays for the urologist?
Well, it's really important for the urologist. We're struggling, and I have quite a few guys that I'm nursing along. They've been put on hormonal therapy for biochemical recurrence, and a decade ago, I think we used hormonal therapy like candy for PSA recurrence. There were tons of patients who got put on hormone therapy irrespective of their risk group, and so now they're coming to castrate-resistant disease, and they still don't have metastasis. With regard to Strive, for example, one of my concerns is, why did they use bicalutamide 50 as their control group? Many times, if we're trying something that we can use, we'll use Casodex or bicalutamide 150, which was the dose in the old EPC trials that we used. I've had some experience using nilutamide. Heck, urology residents don't even know what that is, but that is a drug that can be used. The challenge there is it's quite expensive, even though it's generic and it's an old drug. apparently only one company produces, so it's actually more difficult sometimes to get nilutamide in this setting. I wish we could use abiraterone. I wish we could use enzalutamide. The data is looking strong, but we can't typically use it because it's off-label.
Well, which came first, the chicken or the egg question in CRPC is, yes, these drugs are, if they were become available, we would use them and it would be good. We would be treating PSAs,
yes,
right?
correct,
And
yeah.
so that's one of the issues.
Right.
But then the other issue is what happens at the back end.
The receptor.
You know, if patients can live out the rest of their life to a normal life expectancy with their cancer controlled on enzalutamide or abiraterone, that would be a great thing. But if we produce a more virulent form of the disease at the point of resistance, that could be a problem. So we just don't know that question.
And that's years down the road. I mean,
Yeah.
that's a many-year study. I mean, we're upregulating these receptors. We know that we're going to change the binding domains down the road. So as you said, we're going to, maybe we make a more lethal cancer. So.
And that's why, as much as I'm in favor of interim endpoints for clinical trials and support that, and it's worth having that conversation, we still need to look at survival.
Absolutely.
I think that's the biggest challenge, Chuck, that when you look at the failure when we have developed clinical trials for CRPC in the M0 patient population is that the gold standard for us for registration in this country remains survival, right? So the question is, if you're able to delay radiographic progression, if you're able to delay time to PSA progression, is that meaningful enough that will become a surrogate marker for outcome, i.e. survival? And I don't think we know that yet. So in the absence of that data, I think that we still don't have treatment options for these patients, but more important than that, when you think about how do we truly define M0 patients, right? I think all of us recognize the fact that M0 patients do have metastatic disease. Perhaps it's the technology that we're using that is not allowing us to detect that metastatic disease. We continue using technetium-99, perhaps with better imaging techniques where you use choline PET or sodium fluoride PET. If you detect those patients early, then the question is, would timing really matters? Would put a patient on that trial be, would you see that improvement in outcome? Because as we talked earlier, those patients were not the patients who entered the PREVAIL data. Those patients were not the patients who entered the Cougar 302 data. Right. So I think that's a big question.
I don't look at it and say, does this patient have metastatic disease or do they not have metastatic disease? They all have systemic disease.
Correct.
And that's really the crux of the issue for me. But on the same token, if I'm a clinician making a decision about whether to treat a patient, and I know that the data, the level 1 data we have with enzalutamide and with abiraterone has to do with patients who had technetium, old school bone scan positive disease, that if I'm making a decision based on those old school techniques, I know that I'm in the same ballpark as other clinicians and what the FDA approval is all about.